Welcome to this OR Live webcast presentation on women's bone health and the effects of osteoporosis. Physicians and health experts from Bon Secours St. Francis Health System will discuss how to maintain bone health as well as treatment options available to patients. OR Live makes it easy for you to learn more. Just click on the Request Information button on your webcast screen and open the door to informed medical care. OR Live, the vision of improving health.
Hello, and welcome to the Bon Secours St. Francis panel discussion on osteoporosis. We're glad you could be here today. I'm Tonya Edwards. I'm a family practitioner here in Greenville at Premier Family Medicine, and I'm joined today by a wonderful group of my colleagues, and I'm going to ask them to introduce themselves, starting on my left.
Hi, I'm Todd Lance, an obstetrician gynecologist with Upstate OBGYN Group.
I'm Jennifer Martin. I'm a physical medicine and rehab specialist at Piedmont Orthopaedics, also in Greenville.
And I'm Emmett Lucas, an orthopedic spine surgeon with Piedmont Orthopaedics here in Greenville.
Wonderful. Well, I'd like to start our discussion today by talking just a little bit about what osteoporosis is. And in its very simplest terms, osteoporosis is a weakening of bone that causes the bone to be more susceptible to fracture. In some cases, that fracture can occur with just very minor injuries, like a fall, or in severe cases, even a sneeze can cause a fracture. If you looked at under a microscope at a normal bone, you would see that part of that bone would look much like a honeycomb. And in an osteoporotic bone, the difference is that the gaps and the holes in that honeycomb would appear to be much bigger. And because of that, bone is weaker and more susceptible to fracture. Osteoporosis or pre-osteoporosis, which is also called osteopenia, currently affects about 44 million Americans, and that translates into about 55% of all Americans over the age of 50, so it's an extremely prevalent condition. The lifetime risk for a fracture in developing countries, especially of the hip and spine and wrist, is about 30 to 40%, so it's a huge number, and in fact that number is very close to the risk for coronary artery disease or heart attacks. Also, you might be interested to know that a woman's risk of hip fracture is approximately equal to her combined risk of uterine and ovarian or breast cancer. Any bone can be affected by osteoporosis, but of special concern are fractures of the hips and the spine. Hip fractures almost always require major surgery and hospitalization, and spine fractures, certainly extremely painful, may also require surgery. For many people, the fractures and the reason they're a problem is because they cause periods of immobility, less independence, less mobility, and sometimes, even from complications of fractures, death can result. Certain people are more likely to develop osteoporosis, and I'd like to talk for just a couple of minutes about some of the risk factors for osteoporosis. Certainly, first and foremost, one of the biggest risk factors for osteoporosis is simply being a woman. In fact, women are about 4 times more likely than men to develop osteoporosis. Certainly, men can develop the disease, and we do not want to exclude them, however. One of the main causes for osteoporosis is low sex hormones, and osteoporosis often develops in women after menopause, and where women can lose about 20% of their bone mass in the 5 to 7 years after menopause. Missing periods in elite athletes, for instance, especially young women, can develop osteoporosis at a very early age related to low estrogen levels. Low estrogen and testosterone levels in men also can lead to osteoporosis. Certainly older age is a risk factor I think many of us are familiar with. And the family history of osteoporosis is quite common. And in fact, if you have parents or grandparents who may have gotten a little shorter as they grew older, or who began to have a stooped appearance as they grew older, likely had osteoporosis, whether they've been tested or not, and you may not know that. Being small and thin is a risk factor. Also, certain races and ethnicities. Caucasians are very likely to develop osteoporosis, as well as Asians and Latinos. Not so much in African Americans, although it certainly does occur. Diet that's low in calcium and vitamin D. Also, Excessive intake of protein, excessive intake of caffeine, which some of us are guilty of, can be a risk factor for osteoporosis. Inactive lifestyle, if you're a couch potato, you may be at increased risk. Excessive use of alcohol or smoking are increased risk factors for osteoporosis. And then certain other things that we can't control quite as well, certain medications that might be necessary to treat chronic conditions like rheumatoid conditions, steroid medications, anticonvulsant medications, also some chemotherapeutic agents can increase our risk for osteoporosis as well. And there are certainly some rheumatologic conditions and inflammatory bowel conditions and other medical conditions that can increase our risk factors. So I wanted to turn it over to Dr. Lance to talk a little bit about women and screening and diagnosis.
And as a gynecologist, treating or screening for osteoporosis is a very large part of what we do, in that 80% of people affected by osteoporosis are women. And this is especially, again, reiterating what was said earlier, that menopause significantly increases that risk, and that women can lose approximately 20% of their bone mass within the 5 to 7 years after menopause. And women that have a hip fracture are 4 times greater risk of having a second hip fracture or other osteoporotic fracture. And 1 in 2 women who are at age 50 or over will have an osteoporotic fracture during their lifetime. This has also become a little bit more increased, as was discussed earlier, about the lower sex hormone levels and many of the changes with hormone replacement therapy that have changed over the last several years. And we're looking at different agents in order to treat the osteoporosis. As far as screening, osteoporosis can really strike at any age, although definitely more prevalent in the older population. There are many simple screening tests that can be done looking at osteoporosis, starting with screening questionnaires, which can be filled out very often in the primary care doctor's office, looking for increased risk factors. And this is one such test that are very easy to kind of be looked at, looking at who may be needing more of a diagnostic test. There are also very screening bone mineral density tests that are often done in community programs and several doctor's offices that can give a general screening test, often looking at hip or wrist or heel markers looked down there. These can be done very simply with no needles, no blood sticks, or anything like that. For actually diagnosing osteoporosis, it's recommended to use what's called a DEXA scan, which is a little bit more elaborate X-ray test, looking mainly at the hip and spine for the bone density. And these are done in people who have positive screening tests or other people have indications for diagnosing osteoporosis. And if someone has diagnosed with osteopenia or osteoporosis, this does put them both at greater risk for fractures, but also more morbidity or more problems based on those fractures, including more pain, longer recovery, and which can lead to even more disability. And looking at routine screening, it is recommended that women age 65 or over have routine screening with something, especially even to the DEXA scan level. Women also who are also at increased risk for osteoporotic fractures based on risk factors should also be screened earlier. And again, looking at postmenopausal women not on hormone replacement therapy, which is a larger population now than was 5 or 10 years ago, should also be looked at for earlier screening. If a person is diagnosed with osteoporosis, they should continue to have DEXA scans on approximately every 2-year basis to look at regression and see how the treatment is going. If someone's had a broken bones or change in posture, shortening stature, then may actually be required to have more of a X-ray scan or an X-ray done looking for actual fractures.
Dr. Martin, could you talk to us a little bit about therapy?
Sure. So I see a lot of patients in my practice who have already been diagnosed with osteoporosis. Once we are giving a patient that name of that disease, saying you have osteoporosis based on these tests, it's important that we really talk about more aggressive intervention and medication than just things like calcium and vitamin D. So once we get to the point of osteoporosis, which is severe bone loss, we're talking about treating with things to help prevent the resorption of bone or to help build new bone. So the primary class of medications that we talk about are bisphosphonates. Those are medications that help decrease the bone loss or bone turnover. And those are the things that you hear the most about, like Fosamax or Beniva or Actonel. They all act in a very similar way, but they're given in a different delivery system. So some of them are given every day. Some may be given once a week or once a month. And we now have a relatively new medication that's only given once a year. It's given through an IV infusion. It takes about 15 minutes, and then you really don't have to remember to take a pill every day. That's also helpful for people that have a lot of GI upset and can't tolerate some of the older bisphosphonates. But these medications really are only helpful in helping decrease further bone loss. In a patient that has severe osteoporosis or is being treated for a current fracture, like a hip fracture or a compression fracture of the spine, we may talk to them more about a medication called Forteo. That medication is what we call an anabolic medication. It does help build new bone, which is different than any of the others. That is given as an injection every day and really can only be given for a period of 2 years. So that's just for a very specific class of patients. It's important if you've been diagnosed with this and you can't take the medication that your doctor's prescribed, that you let them know, because you have to be on something. And so sometimes it's a matter of trying different things until you find the right fit. The other part of treating osteoporosis is that we want to minimize the risk of falling in these patients. I mean, certainly we don't want any of our patients to fall, but in a patient that has osteoporosis, it may only be sitting down funny on the couch or just what we call a ground level fall that results in significant fracture and immobility, and then the complications arising from that. So the other part, in addition to the medication management of osteoporosis that we talk about, is the rehab component of osteoporosis. There are physical therapy programs designed specifically to help reduce people's risk of falling for osteoporosis, and insurance does pay for that. The type of screening that we use when we're talking about therapy for a patient or physical therapy for a patient with osteoporosis, we look at things like, are they dizzy at baseline? Do they have problems with falling? Are they in an environment that's safe at home? So sometimes we send out therapists for home safety evaluations looking at, do they need grab bars getting in or out of the tub? Do they need to have some of the throw rugs around the home removed? And then we also look at their medication list, because certainly certain types of medications, particularly in elderly patients, significantly increase our risk of falling. So in addition to how thick or thin are their bones, which is what we get from the bone density test, we're also looking at what is their, what we call spine health, or their fall risk, in addition to that.
Dr. Lucas, can you share with us a little bit about surgical management?
Sure. As a spine surgeon, the typical type of osteoporotic fracture that I see is the vertebral compression fracture. And this can range from causing just mild pain to severe pain. The good news is they generally all heal in about 4 to 6 weeks' time, or 6 to 8 weeks' time probably. It's a better time frame to look at. The problem is, if you're one of the patients that has severe pain, trying to live with that pain for 6 to 8 weeks can be very difficult. The pain, or typically how we treated these patients in the past, was bed rest, bracing, pain medication, and activity is tolerated. But we do now have a treatment method that is minimally invasive. It's called a Kyphoplasty. This can be done as an outpatient or overnight stay. The actual procedure takes less than an hour to do, and the purpose of this is to help alleviate the pain on an acute basis. It also has an additional benefit that it can help restore the biomechanical alignment of the spine and function of the spine. And I think we have a short video demonstrating this. And here's just a picture of the spine. This is the vertebral body. This is the part of the bone that's broken in a compression fracture. Now, to do this procedure, we do it using X-ray machine. And there's a piece of the bone called the pedicle that we need to identify, and these circles here are overlying the pedicles that we see on the X-ray. This is going to be our landmark for the procedure. And we usually take an X-ray looking straight down on the patient to identify the outer border, as you can see here, and we mark that on the skin. We also use a lateral x-ray. So we do an x-ray from the top and the side when we're doing this. And we make an incision off a little bit superior and off to the side, and then we insert the starting needle down to the outside edge of the pedicle. And we're checking under the x-ray machine to make sure the needle is in the right location.
Is the patient awake during all of this?
Well, this procedure can be done either with the patient asleep, or it can be done under local anesthetic or even a spinal block in some patients. And here is the side view x-ray. And so once we get the needle in position, we align it in the right direction, and then we insert the needle down through the pedicle or the piece of bone of interest. And we're checking on both the front and the side view x-rays to make sure that the needle is in the right location. This is highly dependent on x-ray to do this procedure. And then eventually we want to have the needle all the way over to the inside portion of that piece of bone called the pedicle. And on the lateral view here, we want it to be actually into the very back of the vertebral body, the one that is broken or collapsed. Then we take out the stylet here and we insert a guide pin. And then we take out the trocar. And we insert a larger trocar over this. This is going to be our working portal where we're going to do the rest of the procedure through this. And so once again, this has gone back through the same hole. It's just in the very back part of the bone that is broken. And it's gone through the pedicle, and we've made sure we've stayed outside of the spinal canal, so we're not around the nerves or the spinal cord. And that's why the x-ray is so important when we're doing this. Now, this trocar does have some graduated markings on it that give us some idea as to where the needle, how deeply it's placed into the bone. But once again, this is a highly x-ray dependent procedure, so we're getting most of our information off the x-rays. Then we're going to remove the guide pin and the inner stylet here, and we're going to insert a drill, because we need to create a channel into that bone where we're going to place our balloon, and you'll see that shortly. So with this drill, it goes through the cannula, and then we just turn it. Once again, it has some graduated markings here so we can see how far the drill is going into the bone, but once again, we base most of our information, or get most of our information, off the x-rays, looking on both the front and the side view x-rays. And we want to put this, actually, when we're done, it will be right about 3 millimeters from the very front of the vertebral body. It'll show here going in a little bit deeper, and that is our stopping point. Once we see that on x-ray, we stop.
Is this painful?
Well, for the patients that are asleep, it's obviously not painful, but for those that are done under sedation, it is not. So once the drill is removed, we're inserting our balloon, or our inflatable tamp, and it goes straight through that same trocar sleeve, and it's into the hole that we created with the drill. And the inflatable tamp actually has some markers on it that tell us where it is in the bone, to what depth we've inserted it. There are actually 2 different size balloons. For the bigger bones in the lower part of the spine, we have the one on the top, because we need a bigger balloon to fill the vertebral body. On the upper spine, we use a smaller balloon because the bones are smaller. And then we turn this crank here, and what it does is it puts contrast dye through the device into the balloon that's in the vertebral body. And there you can see that balloon is actually starting to fill up a little bit. Now when we do this, we actually put a device in both sides, because we want to fill up both sides of the bone. That will be important. So once we have both of the devices in place, then the next step is to start turning these cranks here, and that will force more fluid or contrast into the little balloons, and then they'll start elevating, and you'll see what happens. As you start filling the balloons, it lifts the broken bone. And what we try to do is get it back to its original height. And sometimes we can actually achieve that, and sometimes we can't. Depends on the age of the fracture or maybe how severely it's been collapsed. But what we'd like to do is restore it to the height of the vertebral bodies on either side. And when do we know when we're done? When we've either achieved the normal height or when we've put in the maximal amount of fluid into the balloon that will hold, or we reach the maximal pressure that the balloon will tolerate. And then we're done. Now, I think on this video, what it doesn't show is we've now elevated the vertebral body and we have restored its height. We actually have to put cement into this. So we take out the balloons, as it'll show here. We deflate them and pull them out. And then we have some devices that are very similar to this that are filled with bone cement. And we insert those through the needles that you see into the space created by those balloons, and we fill it with bone cement, which gets hard in about 10 minutes. And then after 10 minutes, it's as hard as it's going to be, and we've achieved our goal. We just remove the instrumentation, and all this is done through a small incision. We just sew it up, and we're done.
How quickly do patients get relief from their pain?
They should get pain relief instantaneously. We have a lot of people that wake up in their recovery room and they say, my pain is gone. Now, obviously, the needles that we stick in are about the size of knitting needles, and so there is some discomfort from those needles going through the skin and soft tissue and bone, but generally that is much less than the pain that they were experiencing from the fracture beforehand.
Okay. Well, I wanted to take this opportunity to try to answer a few questions. And so what I will do is I will simply read the question and then open it up to our panel for discussion. And the first question is going to be, what is a BMD test?
I think, I can answer that a little bit. That a BMD test would be a bone mineral density test. And they're broken down into screening type of tests that we talked about a little bit earlier, which are sometimes done in a health fair or things where there may be a heel, something very simple monitor where you may put your heel into a little machine that would screen for bone density. And then a more specific test being the DEXA scan, which is done to actually diagnose osteoporosis.
Okay. The next question, what is the role of hormone replacement therapy in osteoporosis and treatment?
I think I can kind of answer that a little bit too, that from the beginning we talked several times about the lower levels of sex steroids and their effect on bone density, and that postmenopausally women will lose a large portion of their bone mass within the first 5 to 7 years. And hormone replacement therapy has traditionally been one of the gold standards for prevention of osteoporosis. Over the last 5 to 10 years, there have been a fairly significant change in the thought process with hormone replacement therapy. The osteoporosis prevention still exists with hormone replacement therapy, but it's not the main reason that we do use hormone replacement therapy with the newer medications that are out specifically treating osteoporosis. But women who are on hormone replacement therapy do have that benefit to the prevention of osteoporosis. And in the screening guidelines, women who are on hormone replacement therapy really would not meet the guidelines for screening until age 65, where not on hormone replacement therapy earlier in the postmenopausal range would be a time to screen for the osteoporosis.
Mm-hmm. Okay, and this is a question I'm going to let Dr. Lucas answer, please. Can a regular x-ray tell me if I have osteoporosis?
That's a good question. When you take regular x-rays, there are varying degrees of technique every time you take an x-ray. So it is very difficult for me to look at an x-ray and tell for sure if someone has osteoporosis. I can get a good idea if they have osteopenia, but I think that it takes 50% loss of bone mass to really show up on an x-ray. So there's a lot of leeway there where you could have something going on before we could actually tell on an x-ray. So no, I would not go by x-ray for use of determining whether or not someone has either osteopenia or osteoporosis.
Okay. And of course, if there's a fracture present,
Then by definition they have osteoporosis.
Okay. Next question. My grandmother fell and broke her hip and has been diagnosed with osteoporosis. Should our family be tested, or is this just part of aging? Anybody want to step in on that one?
I think, in looking at that, I think it would present a family history for an osteoporotic fracture. That I think it's a kind of a combination answer that her fracture was part of aging, but it should not be happening just because of aging. There's definitely the goal with the treatment of osteoporosis was actually prevention as opposed to treatment. And so I think from a family history point of view that other family members, especially women, especially postmenopausal women in the family, should be screened for osteoporosis. And younger family members should also be doing the best they can to increase their bone density to prevent their future progression.
Okay. My mother fell recently and fractured her hip. They did surgery that night and made her get up the next day. Isn't that too soon? I thought she would need to wait a few days for surgery, after surgery and therapy.
I'll take that.
Please do.
We used to sort of have patients that had a hip fracture go in the hospital for a few days and go in traction, and we'd make sure they were medically ready to have surgery. We'd sort of put it off for a while. But the idea now is that we really want to have those surgically repaired within the first 24 hours, because the patients that are falling and getting hip fractures need to get up and get weight bearing and prevent more bone loss, number one. And number two, we don't want the complications that people get from bed rest. So pressure ulcers, pneumonia, all the hospital-acquired infections that make people really sick that usually are the cause of their mortality. We want them up and moving as soon as we can. And so really that's the point of fixing the hip, is we want them to be mobile, and we want to get them back to as independent as we can and get them home.
Terrific. Okay, this one may also be a good one for you, Dr. Martin. If I'm taking medication for osteoporosis, do I still need to exercise?
Absolutely. And specifically, we're talking about weight-bearing exercise here. So the easiest thing that you can do is walk. You know, it doesn't require a special gym membership or any equipment. Of course, we encourage patients to do any kind of exercise, 30 minutes, 3 times a week at least. You know, biking and aquatics are wonderful for your cardiovascular health. They are not going to affect your bone density. We're talking specifically here about weight-bearing exercise.
Okay. This next question is, I take steroids for lupus. Does that increase my risk? And I'll go ahead and take that one. Yes, if you take chronic steroids, which often is the case with treatment of lupus, then the steroid medications can certainly affect the bone density, and so that it will indeed affect your risk for osteoporosis. Next question. I know women are at risk for osteoporosis. What about men? I think we mentioned that earlier, and I'll let any of my panelists step in here. Certainly women are about 4 times more likely to develop osteoporosis, but many men can develop osteoporosis as well. Generally in men, they're going to develop osteoporosis at an older age because they have a much slower progression of bone loss over time. But also, if men are treated for chronic inflammatory conditions like chronic inflammatory bowel disease, rheumatoid arthritis, lupus, diseases that might be treated with steroid medications or use of chemotherapeutic agents if they've been treated for cancer, they certainly can develop osteoporosis. And one of the problems with that is that men are much less likely to be diagnosed with osteoporosis because they're less likely to have it. So we as physicians do need to be very aware and have a high index of suspicion to be able to pick up men with osteoporosis.
It seems like a lot of times their identifying event is a fracture. You know, they don't go through the screening that our female patients do, and then they present with an atraumatic fracture, and then we think, oh yeah, I guess, you know, they probably had osteoporosis too. I mean, obviously they had it. That's why they fractured.
Right. Okay, I'm lactose intolerant. How can I get enough calcium if I don't drink milk? Maybe Dr. Lance or Dr. Martin could address that one.
I can
Okay.
answer that
Okay.
one. I encourage my patients who are postmenopausal, so females specifically, to take calcium and vitamin D. You need to take that as a twice-a-day dose. If you're taking all of it in one dose, you want to absorb the calcium that you need. And it's important to get a supplement that's both calcium and vitamin D. We have found, especially in a lot of recent studies, that patients are vitamin D deficient. That's something your physician can check with a lab. But you could take all the calcium in the world, and it's not going to do anything for your bones if you don't have enough vitamin D to absorb it and make it active.
Mm-hmm.
And I think also in the premenopausal woman who is lactose intolerant and younger women who may not be eating many dairy products and things for whatever reason they want to, supplementing calcium and vitamin D in the younger age group, I think, is also very important that we need to not forget, and looking at prevention as opposed to treatment too.
Mm-hmm. Good. Okay. If I broke my arm when I was a child, does that mean I'm more prone to osteoporosis? Dr. Lucas, I'm going to let you answer that one.
Okay, I'll take that. Actually, when you break a bone at a young age, when it heals, it actually heals stronger than the bone was before. So that would really not set you up for any type of risk of osteoporosis. Now, healing a fracture late in life may be a different story, but as a younger than 30 or younger than 50, I would think that the bone is actually going to be stronger and less likely to develop osteoporosis.
Okay. Why is weight-bearing exercise or strength training so important?
We talked about that a little bit.
Mm-hmm.
I mean, that is the type of activity specifically that we're talking about to build bones and protect bones.
Mm-hmm.
And so again, we recommend that the patients seek other types of exercise, but specifically when we're talking about bone health, we're talking about weight bearing and walking.
Okay. Are there back surgeries besides kyphoplasty that will treat compression fractures?
There is another procedure. It is called vertebroplasty. It's very similar. The difference is with the kyphoplasty, we saw that we could actually stick the balloon into the broken bone and inflate it to try to restore the normal height. In a vertebroplasty, you do the same thing, except you don't stick the balloon in, you just inject the cement. So it can make the bone hard right away and get rid of the pain, but it doesn't do anything for restoring the height. And there is some feeling in the medical community that restoring the normal height of the bone, or trying to get it as normal as possible, restores biomechanical function and prevents or helps limit or minimize the risk of developing further fractures.
Okay. My doctor recommended back surgery for osteoporosis in my back. I'm afraid of a long hospital stay and rehabilitation. What can I expect?
Okay, I'll take that again. There's not a surgery for osteoporosis. You have to have a vertebral compression fracture, and in general, if you don't have much pain and it's not very limiting, we would not recommend a surgery. But if you're one of the patients that has severe pain and is very limited on your activity, then a kyphoplasty would be an excellent procedure. The nice thing about it is it takes less than an hour to do. I generally, you can send patients home the same day. I generally keep them overnight so that I can get them up with therapy the next day and walk them. But once again, the cement is hard in 10 minutes, so you've accomplished what you wanted to accomplish 10 minutes after the cement has been placed.
Well, what would you say about rehab for post-surgical patients in this case?
So I would say that patients actually are usually feeling better after surgery, which isn't always the case. We usually recommend to limit their lifting, and mainly that's because of symptomatic relief. So we find that patients that have fractures, if they're lifting heavy things, that tends to aggravate their pain. I don't know specifically how long Dr. Lucas keeps them on lifting restriction after.
I generally keep them for about 3 months. Now, there is some increased risk after you do a kyphoplasty of developing a new fracture either above or below where you've had the procedure done, and that's easy to imagine. You've got one bone that's really hard and the bones above and below are soft. So I think that one of the things that needs to be done is you need to make sure that patients are getting adequately treated for their osteoporosis as soon after you identify a fracture or treat it as possible, so that the remaining bones can be strengthened as much as possible to prevent further fractures.
Dr. Lance, maybe you can answer this one. At what age do I need to be concerned about osteoporosis?
Yeah, I think in the first thing, being concerned about osteoporosis, I think the best answer is at all points of life. I think the younger women, especially, and younger men should be thinking about building the strongest bone that they can. Studies show that most, especially in women, hit their maximum bone density at age 20 to 30. So the younger women need to be treating or thinking about osteoporosis and looking at how can I get my bone the strongest, because I know once I'm 20 or 30, you're going to start seeing some decrease. So I think that's the answer as far as at that point. And then as women age, they should be a little bit more concerned about that and making sure that they are keeping up with their calcium, so that, because bone constantly goes through remodeling where you're losing some bone and gaining more. And what happens at the age 20 or 30 is that you start losing a little bit more than you're gaining. And it's not a drastic, kind of drop off until, especially in women around the menopause, where you can see a more drastic drop. And along those lines, and looking at what point screening, we talked a little bit about that earlier, that on average at age 65 would be a time to start looking at the screening tests that are more diagnostic, such as the DEXA scan, but younger people, especially with risk factors, should be looking at it even in the 40s and 50s.
Okay, let's try to address one more question here, and then we'll begin to wrap up. This question is, I've heard that there are concerns about young female athletes developing osteoporosis. How does this happen to a young active woman?
I'll take that one.
Please.
I see that some in my practice. There's what we call the female athlete triad, which tends to involve over-exercising, amenorrhea or not having periods, and then some stress fractures resulting from osteoporosis. So I've seen patients who are in their 20s who are marathon runners, who are running a marathon and develop a stress fracture in their hip during the event. They haven't even fallen. And sometimes they actually complete the marathon on a broken hip. And these women absolutely need to be treated the same as our postmenopausal patients that have osteoporosis, because essentially they are postmenopausal in that they're not making enough estrogen to protect their bones. Again, these patients, like men that we see with osteoporosis, tend to not be identified until they've had a significant event like a fracture. This disease really is a silent disease until you develop a fracture. So it's important, especially in our healthy young females who we see that are very thin and that are exercising maybe even more than they're telling us, that we may want to consider screening them as well. And once they have had a fracture, absolutely they have to be treated with one of these medications that we talked about earlier.
All right. Well, before we wrap up, I just want to ask you all, is there anything else that we maybe haven't covered today that you would like to address before we finish up?
Well, the one thing I would say is, and just to reiterate what has been said before, that once someone has an osteoporotic fracture, they by definition have osteoporosis, whether it's a hip fracture or a spine fracture, and they need to talk to their primary care physician, because what's been done to that point appears to be not enough. They need more aggressive treatment. So I would just recommend that every patient who has developed, whether it be a spine fracture, hip fracture, or wrist fracture, go ahead and talk with their primary care physician to see about possibly more aggressive treatment than what they've been receiving up to that point.
Okay.
I would think along those lines too. The other thing I think I'd like to stress too is that probably what we want to do is not necessarily treat osteoporosis, but prevent it. And I think that was their biggest impact that can be kind of had in osteoporosis.
Okay. Well, I'd like to thank our audience today for coming, and hopefully this has been something that's been useful for you. Maybe we've answered a few of your questions. I want to thank the panelists for being here today. As I think everyone can tell at this point, osteoporosis is a serious condition. It is a chronic disease, but it can be managed, And as Dr. Lance said, we want to try to prevent it as much as possible. And toward that end, I would just mention in closing that St. Francis does have a comprehensive bone health program. And if you want to learn more about that program, you can go to the St. Francis website, which I believe is www.stfrancishealth.org. I hope I said that correctly. And, of course, all of the panelists will be available to answer any questions that you might have afterwards. Thank you for coming.
Thank you for watching this OR Live webcast presentation on women's bone health and the effects of osteoporosis with physicians and health experts from Bon Secours St. Francis Health System. OR Live makes it easy for you to learn more. Just click the Request Information button on your webcast screen and open the door to informed medical care. OR Live, the vision of improving health.